Hello friends, I am Dr. Bharat Modi from Wellcare Hospital, Vadodara. I have spent what I would think is almost an entire lifetime working in the area of total knee arthroplasty and arthroplasty at large, but certainly much more focused on the total knee arthroplasty. And on request of my fellows and students, I have decided to come up with a series of lectures which will take you through what I would consider as a primer and as an overview of understanding the science and art of arthroplasty.
So, the most common deformity, see, just to recap, in the present series of these lectures, we have looked at the history of how the art of and science of total knee arthroplasty evolved. Then we looked at how the implant designs, which are part of the history lecture, but also the logic of what are the different types of implant design rationale and what is the logic behind them, is also what we have seen. Then we started with the surgical technique part of the entire story, and that we started with approaches, the various surgical approaches that are available as an option to the surgeon and the nuances of those approaches. And then I think we went on to the primary bone cuts, the standard bone cuts and soft tissue releases that are required for a standard total knee replacement arthroplasty. And now what I suggest we do is to try and understand the nuances involved in different types of specific deformities that you will encounter during your career as arthroplasty surgeons. The most common being varus knee, and that too severe varus. And by the word severe, it could mean either severe in form of excessive looking, sort of deformed looking knees, or severe as in very tight. The deformity might not be that pronounced, but actually they can be far more difficult to handle than a knee which has got 30-40 degrees flexion, varus deformity, but it is a correctable deformity to some extent. And these can be much easier to treat than a knee which is only 7-8 degrees varus and yet will give, which is unyielding on the table. It will not allow you to get your rectangular flexion and extension gap. So let's see what these nuances of this issue are. So managing severe varus deformity in primary TKA. Next please. This is something, hold that slide, go back. This is something that has been routine certainly in my generation of surgeons who started off. When we were going back about now I would say 15 years now. 15 years back our clinic was, OPD was frequented with all these as a routine part. It is only now that the society has accepted this procedure to the point where most of the cases you encounter are reasonably okay. I mean they are mild to moderate, not severe. But you will have this as a regular part of your practice for the next 20-30 years of your career. In the West, these type of deformities are rarely seen, you know, and so many times our surgical colleagues from Europe and America were just stunned at they were at their wits' end and that too we would do it with the most basic of implant choice and instrumentations, you know, the most basic. And initially they thought this was all conjured and fake until they realized that they were seeing this again and again from India, in all different parts of India. And then now of course they salute our fraternity from India in their prowess to handle these severe deformities, and that too with, as I said, very basic means. This man, his name is Subhash Dubey. He came from Indore. He was a teacher all his life, and you can see how severe the deformity was. And this is not something that is unusual even today, as I said. And I'll show you later how he fared following his surgical procedure. Next please. So that was his X-ray. And what are the features that you see in these X-ray? Let's say with the left side. Ashay, give me a comment on what are the features that you are seeing in the left side of this X-ray, left knee X-ray, AP view.
This is a AP view of both the knees, showing varus deformity in both the legs. On the left side, I can see again severe varus deformity, and I can see subluxation of the femur and tibia. I can see bone-on-bone contact. I can see osteophytes around the femur and the tibia.
Good.
And
That's it actually, I think. You have covered the most of the issues that you need to cover. Now, you have superbly described the different aspects. I would like now you, for example, to comment upon anyone, let's say the subluxation part. How does noticing a subluxation translate into its impact whilst doing the surgery itself?
So the first thing would be that your surface marking, you have to be aware that it's a subluxated tibia. So even your incision has to follow the tibia a little bit. As far as the tibial tubercle is concerned, your surface anatomy should be accurate in that sense. Your lateral sided structures will be under tension, and your medial sided structures could be contracted also, so that will affect.
When you say under tension, what do you mean by that?
Elongated, as in
Elongated.
Corrected. Okay, good enough. Let me stop you at that. Anyone who would say, if I say, is there anyone who wants to comment on that lateral side elongation? Any extra comment that comes to your mind? Okay, let me challenge you in another way. If I say there is a possibility of a lateral side structure being contracted, can you understand why would I be saying that? Would I be wrong, or is there a reason why I am saying that the lateral side structure can be contracted given this scenario? Not IT band. IT band also would be stretched out actually. So, what? Huh?
Posterior rotation with the deformation of the bone and tibial contact.
There is one structure which gets shortened, yes, popliteus tendon. The popliteus muscle comes from here and then turns into a tendon and goes like this. So now understand this. This is your popliteus tendon. If it was like this, the popliteus tendon would be this long. But because it is contracted, it has allowed because it has subluxated, the subluxation has allowed the popliteus tendon to stay in a shortened position for a long time. So paradoxically, you might find once in a while that your popliteus tendon is a contracted structure, and once in a while you might have to actually release it. That's one part. So at the surgical level, see, this is very important. And most of the time what you will do is wear a shape, and then your mind has not processed the implication of what you are seeing. And if you have not processed it, you will do it, but you will do it on table, groping your way like a blind man in a room. You will eventually find your pathway out, but it will be a slow, laborious, tedious process. And if you have already internalized it, for example, when I start a knee, one glance, but I mean, I have all silver here, and you guys have a couple of you here and there, So the point is that when I look at an X-ray, my brain has already processed the surgical steps that I will have to incorporate as part of this picture. So I will now start explaining what I mean by this. Everything just on the X-ray part of it. So one thing, the stretched out lateral structure, which Kshitij mentioned. How is it a challenge? The challenge would be you cannot contract the lateral structure. So the only thing you have available is to ensure that you open up the medial side well enough for you to balance it out, and that balancing both in extension and in flexion. So one is I would be aware that there is likely to be a mismatch in the medial space of my extension and flexion gaps as compared to the lateral. number one. Number two, the popliteus thing that I said. Number three, during reduction, I am still sticking only to the subluxation part. During reduction, I think I told you guys, you know, you have to, your assistant and your team have to know that they have to press these things into alignment. Otherwise, your insert that you will do will not be that easy an event. And many times, the surgeon not realizing why his insert is not sitting on his modular tray, tibial tray, he will keep on hammering, and whereas all that is required is for the team assistants to align the femur and tibia. And once that happens, the spine and the cam mechanism then captures it, and then later adaptive soft tissue changes do the job. Because remember, the soft tissue envelope around the knee, it is we who reduce it down to bands like lateral collateral ligament, medial collateral ligament. Actually, it is an entire unitary structure. That's entire capsule is a unitary structure, and there are nuances of contractions, elongations that would have happened in other parts of the capsule, which we don't even discuss as part of crystallized events or thoughts. But this is a fact, and a sensitive surgeon should be aware of this during discussions on conferences or across the table, because you cannot account for every fiber as a separate entity, and so it's okay. You can answer questions like iliotibial tract and lateral collateral as if these are the three structures that make up the lateral side of the knee capsule. There are other fibers. I mean, where do you start with the iliotibial tract, the first fiber, and where do you end as the last fiber? It's not going to be possible on table to know that, you know. So this is about the subluxation. Let's come to the medial side.
One second. When you said you have to release the popliteus, where do you release it from?
Very good. So if you at all go up to that level of understanding and requirement, the popliteus tendon, the techniques that you will find somewhere in the literature mentioned by someone who has gone into that tiny little detail is a Z-plasty. A popliteus is like a band like so. So you do a small cut here, and then exit out here, and then the popliteus tendon is just supposed to sort of slide while still maintaining some continuity for later on fibrotic healing, you know. But you will find many times that when you do your posterior femoral condylar cut in tight popliteus, you will end up transecting the popliteus tendon as well. In my early days, I used to get very worried about it, you know, and flustered that, oh, my saw blade ended up damaging that popliteus tendon. And later on I realized it doesn't matter. It heals up by fibrosis, and the overall stability of the knee is adequate enough to keep the popliteus tendon in position in the post-operative phase, and then the fibrotic healing allows it to join. So don't get too tense if you see a popliteus tendon which has been inadvertently, not as a deliberate act, but inadvertently it has been damaged. Don't get too flustered by it. Now, medial side. Medial side, what is it that you are seeing?
So, medial collateral ligament would be contracted on the medial side, along with the capsule as well, and there is subluxation towards the lateral side.
No, that has been described. I am saying, can you anticipate what it will translate into when you are doing actually the surgical act itself?
So there might be a bone depression on the medial scapula as well, which is not clear because there is bone on bone arthritis. Then the MCL would be too taut, so we have to be careful while releasing it.
Good. So what will you do?
Even retraction as well.
So what will you do for that MCL, Mahesh? What will you do to? So he has recognized that the MCL will be very taut, and therefore you have to be a bit careful about how you are releasing it, in case you don't release it completely and it suddenly gives way. But then, what will you do? Looking at this X-ray, what is it that you will do to make it into a careful exercise? Shiv Prasad, do you have a comment? Remove the medial osteophyte, this built up. So this itself, see, here is your MCL soft tissue shadow, and then it goes like this and like that here. Now you remove this osteophyte and that itself will decompress, so you start getting some leeway in your MCL, right? So my point is, work it backwards. My brain has perceived this osteophyte. You guys have even described it, but you have not translated it into a surgical action on table, which is what I want you guys to encourage yourself to be capable of doing. My brain has already translated that, okay, when I go here, first I will safely take this osteophyte out so that I decompress this ligament, and that makes it safer. Why is a very taut ligament at risk compared to a ligament which is not that taut? Why?
Even a slight blade.
The slightest of sharp blade, if it hits that ligament fiber, it will cut it. So once you decompress it a little bit, it becomes safer in that sense. So you take this out and that will decompress it. Anything else you will anticipate on this side? Kshitij, do you want to comment?
Tightness.
Tightness, yes, you are looking at this X-ray and your brain has to see what do you see anything here on the X-ray that will have an implication on the table?
Maybe that osteophyte.
Yeah, not osteophyte, but this thing that you see here.
Classified or osteophyte.
Yeah, in the sense, osteophyte is classically described as something which is attached to the main bone. So, is it a loose body?
I think it's within the MCL.
Very important. That exactly, that's what I am saying. It is within the MCL. You will find this to be a very tricky thing to remove. The moment if you don't remove it, the MCL will occupy the space of the MCL and it will not allow that much of laxity to accrue towards the MCL. But to take it out itself is a very delicate and precise act. It's almost like taking a pea out of a pea pod, but very gently aisa karke, and then with the tip of your bone nibbler, fine bone nibbler, you just crush it, and then either you crush it and in fact leave some of the shell behind. The whole purpose is to remove the volumetric dimension of this tiny little body, which is encased within the MCL fibers. So if you just try to take the last bit out in toto, you will be horrified to see maybe 50% of your MCL fibers separate. Ek wahan par, ek idhar hai. You know. So it's just like, imagine your patella, the continuity of your quadriceps to the patellar tendon is part of the fibers which are actually joined with the dorsal cortex of this patella. If you take the entire patella out, by definition, you will have a deficiency staring at you between these two. So the aim is to just take this volumetric out, and that tiny amount of cortical fragments might as well remain with the fibers of your MCL. Remember, these are extremely fine points that I am embellishing for you guys. Nowhere in the textbooks will this be described. No teaching session, no conference is going to. This is something that surgeons who are intuitive surgeons would have developed as part of their technique, and only if the next generation is sensitized at this micro level will hopefully they make it part of their intuitive practice of that surgical act. So again, so we have dissected the implication of this side of the X-ray appearance, this side of the X-ray appearance, and then I think someone mentioned about the bone loss, or they will see at cavity. No, it's not might be, you will 100% see, and that bone loss, how much bone loss is present is also a very important part of preemptive understanding of what will you see on table and what you are likely to then do on table. So just see, the bone is like this. In your mind's eye, make the bone arm straightened out like this, and you will see that this, which at the moment looks to be at the same level, will suddenly become like this, and the medial side will go down like this. So when you take your bone cut, you will get a deficiency on the medial plateau side, and depending upon how much bone loss you are estimating visually, you might have to preemptively be ready for either wire and cement or screw and cement, or an extender rod, or an augment and an extender rod. So if your eye has not picked up on this, because your brain was not aware of the implication of what it is, then it is on table that you will find that you have neither a extender rod, or you have not mentally even thought about putting those wires, you don't have an augment on hand. So be prepared. And lastly, although it's unlikely, but lastly, you might want to be mentally ready once in a while for a TC3 type of a capture. See, typically you would be using either a posterior cruciate sacrificing or a cruciate retaining components. But let's say, despite everything, you find that there is too much laxity on the lateral side. Now what do you do? Because if you leave it in too much laxity, the patient will still have a waddling gait. There will be a lateral lift off, what is known as a lateral lift off, so that with every stance gait, during the gait cycle, the stance phase will load the medial tibial plateau plastic hugely so, and therefore there will be an earlier failure of the plastic. So ideally you should not have a lateral lift off. A lateral lift off occurs
Instead of using the TC3, which is a much bigger step than I expected, can we do lateral side reefing of the LCL?
So good question to have in mind. There is zero possibility of any type of reefing holding against the body weight that happens, zero possibility. So there have been theoretical possibilities of doing a lateral epicondylar osteotomy, proximalizing it and fixing it again. I think rather than that, just putting a TC3 type of a femur component, presuming that the implant system you are using allows you that upgrade. So again, these are very early stage thoughts that you have to process in your brain when you look at the X-ray. That's why I am telling you guys, you have the opportunity to learn so much in front of you. In my days, we did not have WhatsApp or anything. Here you have the X-rays of tomorrow pulled, and yet, to be brutally truthful, you can edit it out if you want to, for the sake of the dignity of these guys here. But you guys come as clean as a freshly bought slate from a kindergarten education store. You so many times I catch you out. You don't apply your mind to preemptive thinking. You have to think on the X-rays. You have to try and goad yourself. What is it that I have to think here? After you finish your operation, your brain has to revisit the X-rays that you had sort of looked at. Once you finish your surgical exercise and then you become embroiled, your brain becomes embroiled in whatever exigencies that are brought to you by life, and it will be different for each one. For him it could be something to do with the hospital management, blah blah. For you it could be your girlfriend. For him it could be the recently acquired twins. For you it could be a job application. I have no idea. The only one who does not have any such issues in life, the only one person I have found consistent in my life is sitting there, who doesn't seem to have any janjat in life except what he has decided, this is my janjat, nothing else, So, but that's a very rare human being you will come across, Rao Saab. But otherwise, you guys must develop this habit of revisiting. Otherwise, you will never become a surgeon of the caliber that the opportunity presents them. So, the bone loss is also a very important part of your assessment at this level. One is, will my cut, tibial cut, take away, equalize it to the point where now all I have to do is put a bit of maybe 1 or 2 K wires or screw heads and cement, or will it be so much that I better adopt an implant system which allows me to migrate to a highly constrained or fully constrained femoral and tibial combination, which means a TC3 type. At our place, the only system which I think allows us on table migration that we have in terms of instruments and everything ready at the drop of a hat is the PFC Sigma system of J&J, Dipiosynthese, which allows you that okay, instead of the PFC Sigma femoral component, you do one step higher notch cut and now box cut, and then put on a TC3, and then the tibial tray is the same. The insert becomes different. So these things you have to have. If you become a prolific enough surgeon, then you should have it as part of your routine stock in the theatre. And if you are not so, and therefore the company is not going to provide you, or a dealer will not provide you every time you do this surgery, then it is even more important that your brain processes this, and once in a while, in a case where you anticipate that, you make sure that it is lying in the theatre when you are doing that surgery. So that you can see.
Measured resection. Do we take 9 mm from the less worn out, or
Absolutely.
or the 1 mm from the most worn out?
So that's a philosophy you will have to take on, but I normally take 9 mm from the less involved.
That's a philosophy you will have to take on, but I normally take 9 mm from the less involved. Because once in a while you might have such a deep excavation that 1 mm from the affected side will leave you with a massive gap, which can be frightening sometimes. So 9 mm from the less affected, and then the remaining residual deficiency you see on the medial or more affected side, you built it up depending upon how you.
So another question is, when you talked about the building of the medial side, at what measurement do you decide whether you have to put cement or augment? Like, is it 2-3 mm of cement, and beyond that I go for an augment, or what is the kind of?
So we will come, there is a separate lecture on how to build up bone loss in primary TKAs, and that's a very graded methodology of how to deal with bone loss. So there are guidelines. Anything less than 5 mm you can do it with bone and things. Between 5 to 10 you are well advised to do either a bone graft, if you can find a structural bone graft appropriate for it. In other words, let me cover it when we reach that. It's a subject in itself, or it's a subject for a lecture in itself. How to build up bone loss, and read up on the classification of bone loss. So I know there are many classifications. Brand and others, and Dor classification, brand classification, many. But the one that I found to be most useful, and I think is adopted by almost everyone across the world, is the Anderson AORI, Anderson Orthopedic Research Institute classification of bone loss in total knee arthroplasty. How to classify and grade it. It's a very simple and yet extremely useful classification. So read up on it before we reach that stage. So how to do severe, you can see how much expansion happens. We have not moved, I think we are almost exhausting our timeline for the morning talk lecture, and we have not moved beyond just the AP view. अभी तो lateral देखा भी नहीं है. Next please.
No, I have a doubt while we're on the deformity. So there has always been a slight confusion when talking about varus deformity. Those rare cases when the deformity is not in the shaft, but it is at the metaphysis.
Very good.
And that is very dangerous when we are putting the jig and we are taking a cut, and we don't realize if the deformity is at the metaphysis or is it the whole tibial bone. So how to go about it?
Super. So that's a super point he brought out. I had it in mind, but I would have missed it. So when you talk about varus deformity, the varus deformity can come from three different levels. One is from within the joint, which is usually due to the bone loss of the articulating ends of the bone. So more and more bone is worn out and the tibia keeps on going into varus. Usually the bone loss is on the tibial side, but there will be some amount also on the femoral side. But it's very rare to have deep excavatory worn out defects on the femur side, unless it's a case of previous trauma or osteonecrosis of the lower end of the femur where an entire chunk of bone has just gone out or something like that. So usually it's in the tibia, the bone loss part. So one, the varus deformity is caused by bone loss at the joint level. Second, the deformity is contributed by a adaptive or a genetic predisposition of tibial varus, not tibia vara, because the word tibia vara is associated with a pediatric specific condition, Blount's disease, So, but a genetic predisposition or an adaptive disposition, which we see in Indian women, portly ladies who have been walking on gradually increasing varus knees, and their knees undergo adaptive changes both in terms of metaphyseal molding into varus. And how does that happen? It's not difficult to in fact, here this is a good example. See, if you see here, and I am not repeating all the features we discussed here about the osteophyte, etc. But see, the original bone, and I don't know whether you can appreciate that from that point, the original bone was here going like this. This triangle that you see here is an expanded metaphysis, physiological response to the stress coming on this side, and the body is responding to hold up that weight of the body here by putting extra bone here. So now you can see that it is what looks like a metaphysis actually going like this. So the deformity, there is an angular deformity here actually, So the same thing can happen in the entire, distributed over the entire tibial shaft. So you can have deformity of a varus constitution contributed by the femoral bowing and the tibial bowing of the shafts, adaptive changes at the metaphyseal region here in the tibia, or bone loss at the within the joint itself. Three different contributing factors towards the totality of the varus deformity that you see. Now of that, to answer your question, the bone loss is going to be compensated the moment you put your insert, tibial train insert. For example, if there is a 8 millimeter excavatory defect, let's say even a 10 millimeter excavatory defects, almost 90% of that bone loss defect is compensated the moment you put your artificial component, of minimum 8 millimeter thickness, but usually maybe up to 10. What will not be compensated? The deformity contributed by at the adaptive metaphyseal level, or the overall bowing of the femoral shaft and the tibial shaft. However, and this is where it comes, when your question was, okay, it is a bit confusing what to do. So repeat your question, and now I'll answer it.
Okay. So my question would be that when we are putting the tibial jig for the proximal tibial cut, once in a while, if in the rare circumstance where there is a deformity at the metaphyseal level and there is an angular deformity, and we straighten the leg, put it perpendicular, push it back in high flexion, and then we put the tibial jig, there could be a situation where we are cutting off the cortical bone on one side, which usually we would expect that in a straight leg we are cutting off the top part like 8 millimeter or 9 millimeter cut. But over here, because of the angular deformity, we are cutting cortical or cancellous bone, and could that be a problem?
From which side? Lateral.
Yeah, lateral.
So let me first of all make you understand the entire concept of mechanical alignment. There is no anatomical structure called a mechanical axis. There is an anatomically you can trace anatomic axis, which is along the line of the shaft of the femur. The mechanical axis is actually a conceptual line. So all those curvatures of the femur shaft, tibial shaft, including any curvaceous metaphyseal adaptive changes that might have happened, are to be ignored. You don't have to take that into account. So in other words, if I am putting my tibial jig here, cutting block here, and then the tibial jig on the ankle, all I have to do is to make sure that my tibial, and this is as far as the manual conventional instrument method is concerned. We will quickly refer to what happens during navigation. Robotics is nothing but a little bit of mechanical action added on to navigation. But we will come to navigation in a moment. First, let's use the mind's navigation, which is quite adequate. So when you have your tibia straight, like this is the foot. So you have it straight aligned like this, vertical to the horizontality of the ground. Then also from the lateral side you ensure that it is straight. From the medial, AP side also, it should not be like this. It should not be like that. Once you have arranged your tibial vertically, like so, now you have clasped your proximal tibial cutting block here, clasped the ankle with those clamps. Now you slide it here and there, ignore the bent of the tibial shaft. Now you just have to make sure your mind's eye and brain has to process the midpoint of that tibial block here and the midpoint of that lower, that's the jig shaft here, and they have to be in line. If that is looking skewed like this or like that, then you are making a mistake. The moment you getting it? If not, you can then look at the later on in the OR, you can ask me with the actual jig there in place in front of you. So you can ignore this, or in fact you should ignore this, and as long as you get like so from midpoint here and the midpoint down there, if that is in a straight vertical line, then the cut that you are going to make will bring the overall alignment of your limb into that conceptual mechanical axis, which is supposed to be at 180 degrees to the in line, to the ground force, ground horizontality of the ground. Am I able to answer you?
So the main thing is to keep the tibial plateau parallel to the OR table or the...
Yes, your cut tibial plateau should be parallel to the table surface, which hopefully should be parallel to, if your contractor has done the appropriate job of laying the floor on your operation theatre, So you are very right. So the tibial plateau has to be parallel to the operation theatre table surface, and this you will be best be able to appreciate by stepping away a little bit. You should not try to assess it at this distance. You have to step away and look at from the far end of the table, and that will very quickly give you your mind an understanding that that looks horizontal, and this is in the AP view. In the lateral view, you will by design want some slope, depending upon your philosophy, 3 degree posterior slope, 5 degree posterior slope. Max is 7 degree, nobody goes beyond 7 degrees, that's too much. But and Y3 and Y5, again we have already gone through all this, that either you be a very purist and try to assess the preoperative slope if you can, which I doubt, because in a bilaterally advanced knee like this, how the hell do you know what was the original posterior slope? So at our place here, we stabilize at around 3 degrees, 4 degrees posterior slope. And why is a posterior slope required? What are the advantages? I think we discussed this early, that a posterior slope contributes towards bringing the flexion gap into easily achieve. I mean, you can reduce the tightness of your flexion by doing a posterior slope, etc. So I think that answers your question. You should not be worried about, and when you say that, when you do that, sometimes it looks frightening that a lot of lateral side tibia plateau is being cut. don't be frightened. It looks more because the medial side is deficient. That is why it looks dramatically high. As long as, and many times I told you earlier on table that it is the osteophytic built up on the anterior lip of the tibia which will give you the appearance of taking away too much. So I take that out, the anterior tibial lip osteophyte. Go to the next, let me see if there is a lateral exercise. Here we go, yeah. So there you see, all, do you see that? That's your anterior tibial lip osteophyte. Now all this, whereas the original was here. Now if you don't remove that, when you put your block and when you are taking with an angel wing trying to see what thickness you are cutting, your brain will yeah, here you go. Go to the next. Let's see if we have a go up to the tibial. So yeah, go back. So see here. Now this is your femur. This is, and now if I apply my tibial jig here, this built up here will give me the impression that I am taking away humongous part. So if you reduce your osteophytic build up, it will, so always do that. In the early phases of your career, and I do it even now because with my dexterity, if I can call it that, it takes me what, 35-45 seconds, 1 minute to remove all these osteophytes. Why not do it? Sat, khada kar diya. Now the entire team is aware, the nursing staff know the moment they see a deformity. So मैं ऐसा करता हूँ तो they give me exactly the curved osteotomy that I want to knock off this osteophyte, straight osteotomy for this osteophyte. They know as much as I do. So it takes me 45 seconds, 1 minute to remove the osteophytes, and now my brain is actually assessing everything based on the original volume of that bone rather than the fake volume. So let's go back now. Go back. In fact, this will stand here. So now in the lateral view, maybe you want to take this as a next session because we have already reached 10:30. As I said, because there's a lot of discussion just looking at the lateral view X-ray. Once you see all this, the remaining sequence is actually just a pictorial demonstration of what we have already discussed, and they will make beautiful sense if you have processed this at this point. Only these two X-rays can make you an expert at this, and then the remaining is only just a pictorial disposition. Okay. So
like you said, we can have Varus deformity at 3 different levels, depending on the etiology. So if there is a involvement at the joint line, that will be possible to be corrected after the surgery. The rest too won't be what I presume, sir, because we won't be touching that part of the bone. And so any other implications we have to be aware during the surgery upon the different deformity levels, like apart from the jig placement, any other step we have
you mean in this particular deformity?
About the Varus deformity, sir, whether it is at the shaft level or the...
No. So you need to, I mean, only if you take a scanogram will you know for sure what is the femoral bowing in the coronal plane and all that. But you don't have to obsess over it. But as I am saying, the moment you take a parallel tibial plateau cut, all those are not going to make a big difference unless you are trying for kinematic alignment and all those sort of things. Then then you cannot just take a parallel cut. Then you might want to iterate. I want 3 degrees of Varus on my tibial plateau cut, and for all that, then you need to be consistently precise. Then you would need navigation. I don't think you need robotics for it, but certainly navigation. And actually, what does a navigation or robot do? They, unlike the human eye-mind thing, which is perceiving the anatomy as reality and the mechanical axis as a conceptual thing, the software of a navigation system, it does everything as a conceptual thing. There is nothing like that robot cannot come, or that navigation system cannot come and touch this. It cannot see the red color of the blood. It cannot see anything. For it, there are some points in space. First you told the navigation what is space. So this is your space. Within that space, you told that navigation thing by virtue of that optical sensor, that data is transferred there, that these points which I have just registered in this space, in this room, one point here, here, and now there is an algorithm that I give you, say, 200 points, you yourself now conjure up the intervening points. So for example, so it is important to understand how navigation works. So unlike your brain, which sees it in totality, the figures that you see on a navigation screen or a robot screen, it's not that the navigation or the robot has perceived all the total volumetric data in an imageless system. In an image guided system, yes. In an image guided system, the CT scan has captured everything, and that entire volumetric data is fed into the navigation or the robotic brain, right? But in those imageless things, where it is on table that you are telling the brain of the navigation what is the shape and the size of the bone you are discussing. So there is an algorithm. You put a point here, ऐसा वो जो probe से you recruit, what they call is recruit point. So you recruit but how many are you going to recruit? ऐसा you paint, it will still be 30%, 40% of this entire area. Similarly here, then in the posterior condyle, then here. So all you are telling, giving the data to this navigation brain is, in this sofa's example, I'll give 1 point from here, 1 from here, 2, 3 from here, 1, 2, 3 from here, and then there is an algorithm already fed in that overall a sofa will have this type of a geometry. So the navigation puts 2 and 2 together and conjures up the overall shape of the sofa. So instead of here, if I would have put my points from here and here, from here and here, it will still come up with a structure which looks like a sofa, but it is presuming that everything else in between will be there. If this handle, this backrest supports stops here, then it presumes that from here to there is material there, and it gives you an image of a sofa. So it is not actually true if your algorithm is a bit biased, because the algorithm you have put in is that of, let's say, giants from some strange island, and now you are dealing with pygmies, then there can be a difference, some difference in but why does it not matter? As such, the act of knee replacement is that you take away the contours that were given by God or disease, and you put a contour which was made by man. So, and that is the whole point I make when I say, what the hell are you talking about wanting to get an exact alignment, etc. As such, you are doing an adaptive exercise. It is a modification exercise. It is not a recreative exercise of bringing back normal biology that existed before. So it's stupid, but then that is what bright brains and eager business end up doing together when they get together. So the alignment part, the navigation, what does a navigation do? This has triggered up from your question, how do you do that? Navigation doesn't have that confusion. Why? Because it has taken the midpoint of the center of the head of the femur, and then the midpoint of the knee, and the midpoint of the ankle, and then it has been told, bring them into straight line. And that bringing it into straight line is controlled by, the moment the surgeon does this and that, he can see on the screen that, oh, okay, I have brought it into a straight line. Now, whatever the deformity at the metaphysis within the shaft of the tibia, in the joint itself, all that is of no importance. All I have to do is to decide, do I take away 8 millimeter of tibial plateau cut or 9 millimeter of tibial plateau cut? He doesn't have any worry, presuming that the system is working okay. There's no malfunction in the software of that system or something like that. Okay, the same thing the human brain can do. When I see For example, here, tell me, is this horizontal to the ground? Why not? I mean, you don't have a navigation. How can you be sure it is not? Common sense. Does that look horizontal to the ground now? From here? Yeah? Now, you can actually test yourself. Bring a small spirit level, put it on top of this, ask your colleague to say from a bit afar, and then when your spirit level is indicating the bubble dot in the center, and if he can say, yeah, now you are parallel, and when you do this and he can say, no, you are not parallel, raise it up a bit, and check yourselves out. I am pretty sure you will get it right every time within a 1 degree or 2 degree max. And it's already well proven in literature that up to 3 degrees it doesn't matter in terms of long-term survival of the construct. So this is a good game to play and become confident about your ability to see these things. So anyway, so this is a very interesting lateral X-ray, and there is a lot to discuss here, but we'll do it in our next lecture. Good, gentlemen, back to work now. Thank you.
Effect of cutting of the popliteus on the rotation of the femur.
A very interesting question Rao has brought in. So, in the 90-degree position, where's the lateral side? Yeah, this side. My side here is the lateral side. The popliteus comes from here, and let's say use this string as a popliteus tendon, like this. This is your muscle. It comes like that, reduces itself into a tendon and goes here, like so. And many times you will have a contracted popliteal. Common sense, the popliteus is actually anchored here, tendon. If you pull it, in theory, a tight popliteus or a popliteus which is pulling will induce, at 90 degrees, it will induce an external rotation movement. If you transect it, that pull is gone. So, in theory, you can have, as he says, on the rotation part of the femoral end, lower end of the femur, it will be influenced by the tightness of your popliteus. It's a very interesting point actually, because a lot of these patients with this severe deformity, and especially in Indian women or whosoever who have a pendulous abdomen, all their lives they have been sitting like this, like so, to accommodate that abdomen here between these two, and they eventually start getting a external rotation adaptive change. So on table you will find once in a while that there is a external rotation contracture at the hip, which at the in the 90-degree position your assistant will have to struggle to bring that femur, have the medial condyle touch on the tibial cut surface, ऐसे नीचे. The femur will keep on wanting to stay in this position, and that is not only from the popliteus would be an adaptive thing, the more powerful would be from the hip. But as Rao pointed out, that if the popliteus tendon has been accommodated in that position all through the patient's last few years or a decade or so, cutting that popliteus will have some impact on the rotation part of the position of the rotation part of it. Yeah, that's a
What about
subtle
the
point.
locking and unlocking of the knee? Will that be
Oh, see, all that locking, unlocking, etc. Applies only when you are talking about a normal knee. The moment you put, convex contours fitting onto the concave contours of a tibial insert, all this is modified after that. That's what I'm saying. Anyone who says that they are trying to recreate normal anatomy, they are kindergarten brains, in my understanding. They are living in cuckoo land. I'm sure they believe in tooth fairy even at that stage of their lives. Okay, great, thanks.